Hello, everyone. Welcome to episode 20 of the Not A-Fib Podcast, powered by the Journal of Emergency Medical Services. My name is Mark Flaughter. You arrive on the scene of a motor vehicle collision to a bleeding and unresponsive patient. This is a leading cause of trauma-related death and a scene all too familiar to those working in EMS. Knowing the patient is likely hemorrhaging and time is of the essence, you do your best to control the bleeding and replace the lost blood with fluids like crystalloids to correct the hypovolemia and achieve hemodynamic stability. Upon arrival at the hospital, the patient receives continued resuscitation with blood transfusions, the gold standard treatment for hemorrhagic shock, replacing lost blood volume with whole blood, which contains red blood cells, platelets, clotting factors, and proteins. If your patient survives, they may be faced with a lengthy stay in intensive care unit, battling cardiac and pulmonary complications related to crystalloid use in hemorrhagic shock. Research suggests that the overuse of crystalloids in hemorrhagic shock increases the risk of many complications, including death. What if you could increase survivability and decrease complications by starting a blood transfusion on scene or during transport to the hospital? This option is the budding reality for some EMS agencies at the forefront of trauma care and hemorrhagic shock management. Hemorrhage is the leading cause of preventable death in trauma patients, with nearly half those patients dying in the pre-hospital setting. Hemorrhagic shock is caused by significant blood loss, which depletes intravascular volume, ultimately leading to multi-system organ failure, and if left untreated, death. Hemorrhage most often occurs after blunt or penetrating trauma, though it is also okay. The data is clear. Hemorrhaging patients who receive blood before arriving at the hospital have a fourfold increase in 24-hour survival. For every 1 minute delay in blood product resuscitation hemorrhagic shock, the odds of 30-day mortality increase by 2%. Receiving blood within 14 minutes of injury is associated with improved outcomes. 14 minutes can mean the difference between life and death. Notably, the national EMS average response time is 7 minutes, with varying on-scene and transport times. Therefore, to achieve optimal outcomes, patients should receive blood shortly after EMS agencies arrive on scene and certainly before they arrive at the hospital. Today, under 2% of EMS agencies carry blood, and just 1% of patients who could receive pre-hospital blood actually get it. Why? That is an excerpt from an article entitled Saving More Lives with Pre-Hospital Blood Products from the National Association of EMTs Fall 2024 newsletter. Joining me today is Holly O'Byrne with the DC Fire and EMS. Holly is a lieutenant paramedic with DC Fire and EMS and holds a master's degree in public administration. She transforms blood administration in the pre-hospital arena with her bold advocacy, cutting-edge education, and a steadfast commitment to transparency. With expertise spanning field training, simulation-based education, and program management, Holly combines precision with visionary leadership to deliver impactful solutions. Her ability to build strategic partnerships and her sharp eye for detail have made her a trailblazer in her field, setting new standards for excellence and innovation. Holly, welcome to the show.
Thanks, Mark. I really appreciate this opportunity.
So before we get into what you've done with your blood program at DC Fire and EMS, let's go back a little bit. Tell us what got you into the EMS field and then ultimately over to DC Fire and EMS.
I actually started volunteering. I got my EMT when I was 15. And then I kind of got bit by the bug. I went to college, started getting a degree in chemistry, and like most college kids was like, oh, wow, I need a job. So I know. I decided like, hey, I'm gonna go work part-time and do EMS. And they were like, hey, you want to get your paramedic? And I was like, oh, do the things that like all the cool people do. And at 18 years old, you're like, wow, the machine that shocks people and you can start IVs. So I decided to get my paramedic. And going through school, I kind of got bit by the bug. I applied to medical school. No offense, I'm actually kind of glad I didn't get in because I'm having a ton of fun right now. And I stayed with it. So I started working for a fire department, stayed for 7 years and said, wow, I want to be what I thought was one of the really cool kids, and decided to fly on a helicopter for a couple of years. And then missed the fire department. I missed the culture. I missed being in a firehouse with people. and having that, brother and sisterhood and the camaraderie. So I came back and went to DC, and it's been a fun 12 years so far.
Oh, good. For those listening who may have an interest or have always wondered about being a flight medic, I personally have never done that, have always wondered about it. Tell us some of the differences that you feel are significant between being a flight medic and then being a street medic, if you will.
So my flight experience was a little bit different. I worked at a primarily based interfacility flight service. We did some scene flights, but it wasn't our predominance. So I missed taking care of sick people. I missed taking care of people in their critical moments of actually being that patient advocate for them instead of picking up a really pretty nice packaged patient.
Mhm.
And the flying is amazing. If you're afraid of heights, don't do it. Not the job for you, right? But the flying was amazing. I got some like really great education out of it. I built some amazing relationships with our trauma center and with the physicians in the ER there, which actually helped with my job at DC Fire.
Okay. When you first came on DC Fire, you mentioned you'd volunteered, so you had some fire experience. Did you work both fire and EMS at DC Fire, or were you pretty much assigned to one or the other?
So I had spent 7 years as a master technician in my former job.
Okay.
So I had a large amount of fire-based training. A lot of it was rural-based, so rural water supply, tanker operations, which obviously we don't really do in DC.
Mhm.
But I was actually brought on the EMS side,
Okay.
and then worked my way up through the ranks. So that's been my specialty.
Okay. Okay. So just a little bit about as we get into the blood program that you have at DC Fire, the integration of low titer O positive whole blood LTOWB into the clinical and operational capabilities of DC Fire and EMS marks a pioneering advancement in pre-hospital emergency care. Traditionally reserved for in-hospital administration, whole blood transfusion was initially met with skepticism when proposed for EMS use. However, through persistent advocacy, interagency collaboration, and evidence-informed design, DC Fire and EMS implemented a system that now empowers paramedics to safely deliver life-saving transfusions in the field. This approach is rooted in a commitment to health equity and strategic resource allocation, with LTOWB carrying units prioritized for communities most impacted by trauma and violence. Since its launch, the program has transfused over 282 units of whole blood, with approximately 77% of patients being victims of penetrating trauma, many in underserved areas east of the Anacostia River. The results are compelling. 82% of all transfused patients survived to hospital admission, and among those not found in traumatic cardiac arrest, 96% survived, far exceeding historical survival rates for hemorrhagic shock. Those are pretty compelling numbers.
They are compelling numbers, and it's because of the work of our transfusionists and it's the work of our field providers.
Did I see recently where you celebrated, I think, your 1-year anniversary of your first administration of blood in the field?
We did. We celebrated it on April 10th. That is the anniversary. And as of this morning, because we transfused again, we're at 262 patients.
Wow. So in 365 days, 262 units of blood, or 262 patients have received blood.
That's correct. Just over 1 year. And right now we were sitting at 284 units utilized.
Wow. That is impressive. That is really impressive. I don't think I think those numbers just speak for themselves on how beneficial this is for your pre-hospital patients.
I think it's also beneficial for our providers as well. We were seeing astronomical homicide numbers and violent crime numbers. In a decade, we saw a rise of 161%. Between 22 and 23, 35% rise in homicides. Our providers wanted to do something more. They knew we could do something more. It was just the what and how.
Mhm.
So whole blood also helps our providers because it's not limiting our scope. It's expanding it to be able to save more lives.
So I guess that's kind of the impetus for the program, was the homicide rates that you mentioned. Talk to us a little bit, if you will, about the journey to get the program started. what were your first steps, and how much resistance did you meet along the way?
So the first steps were talking to people, and I can't express this enough. You can go online and you can look up blood programs at STRAC. You could look and see what Grady was starting to do. You could look and see across the US who was putting information out there. It does not take away from building partnerships from people and listening. There are things even 18 months into this program of learning. I learn stuff every day from people like Randy Schaefer and Dr. Cromer and Dr. Holcomb and Dr. Duchesne and Chief Eric Bank, because I sit and choose to listen to them. This was not a vacuum program, right? I couldn't build this in a silo.
Mm-hmm.
So there were road bumps along the way. Blood bankers are one of them. The one thing about blood bankers is they think very different than EMS providers, and they have to. And if you take it and you listen to what they're saying, it's a great perspective. They are very black and white. EMS is black, 5,000 shades of gray, and white. Like, we live in the no rules land. We have some rules and they're loose, but it's fun. It's a fun color spectrum, right? So you really have to nail down what they're asking you and how to get them that information. For us, we did a 6-month retrospective study. Is blood feasible? Do we have the time to do it? We're a major metropolitan city with 3 trauma centers. And you hear this, and I hear this continually. Oh, I have trauma centers. I'm super close to the hospital. Well, are you? When we started running the numbers, it didn't add up. Just because mileage was close doesn't mean that time was.
Right.
So we had to justify that we would be able to do the entire blood procedure. Okay, and get it started in some instances to start opening up that door with blood bankers. And then we had to start opening up the door with trauma physicians. Hey, we need you on board. You like this plan? And luckily, overwhelmingly, people like Dr. Christine Trankium and Dr. Babak Sarani were huge supporters and gave us tons of information. And I'm very grateful for the time that I had to be able to speak with them. And then we went and said, hey, nurses, we're going to do something new, because I love my nurses, but if you bring in some new skill, they're going to be really unhappy if they don't know about it.
Right.
So we went to every ER on every shift, and we talked to the nurses and made sure they understand our equipment and our documentation. And building partnerships isn't just within the department, it's who else is around you, who else could be impacted.
Right. One of the things that you mentioned was the blood banks. And I'm sure that's for those listening that may be thinking about traveling that road, that obviously is going to be a big concern. So talk to us a little bit about, you mentioned the differences between the thinking between blood banks and EMS. Can you talk to us a little bit about what you encountered with the blood banks as you got this program up and running?
So I was lucky because we partnered with the American Red Cross.
Okay.
And we had very strong support from them. We're lucky that we have one of their headquarters in DC. They understand what we were trying to do and the lives we were trying to save. One of the things that's going to be very helpful is the American Association of Blood and Biotherapies, or AABB, just published the first edition of the pre-hospital blood guidelines. And they were still working through this when we started our program. But now that it's published, it is a guidebook of everything that we had to learn, every standard, and is a really great resource for people who are up and coming in the blood world. This is not impossible. Okay. I just want to make that 100% clear. This is not an impossible feat.
Right.
You're going to have to play by the rules on this one.
So when you say it's not impossible, obviously major metropolitan area, Washington, DC, large department. What about a smaller department that's saying, how am I going to be able to do this? How can I afford this? Can you talk to us a little bit about the financial ramifications, or what you found, the financial aspect of starting a blood program?
So right now, DC funds its own blood program.
Okay.
Depending on the state that you're in, and across the US, let me preface this, on January 1st, the CMS code for blood transfusion is there. Okay. So that's your billing code. All right. Especially if you bill in pieces or parts or add-ons, this is something that you can use. The question is whether or not it is funded. Okay. And that's something you can talk to your state agency reps about. You can talk to your private insurers, especially if you have state-based Medicare or Medicaid programs, and you can do a lot of funding reimbursement from that. Another thing that you can use is the SF4A, which is grant funding to be able to actually start and then continue to support your blood program in your area. I also would say use your resources. All right. You're going to see some clinical practice guidelines come out that talk about warm blood and why it really is best for patients. Warmers have a cost to them. How do you get creative funding? How do you get support from your community for those if you only need one or two and you're having, a little bit of a stalemate on some grant funding, especially in the current economy? There are creative ways that I can say groups of people, and already some of the people who I've mentioned in this podcast can help you with. We are really great resources, and so are even a lot of the clinical reps that deal with the companies can help you get creative in how to fund these things.
You just mentioned the warm blood being better for patients. I was actually approached by one of the paramedics at my agency. We were talking about a variety of factors, and the pre-hospital blood came up, and he talked a little bit about that cold blood can be given. And most people would think that, well, blood needs to be kept cold or it's going to quote unquote go bad. So talk to us a little bit about the difference between the warm and versus cold.
So blood does have to be kept cold.
Okay.
In all of your standards, you're going to look and you're going to see it's got to be between 1 and 6 degrees Celsius. Okay.
Okay.
Blood has a preservative and citrate. That citrate actually makes sure you don't have any bacteria buildup, nothing happens, especially as that blood continues to age. So whole blood, for example, is good for 21 days. We want it to be good that entire time. It's got to stay in that temperature range. When giving it to a patient, though, you really need to look and warm that blood. So we talk about the diamond of death, right?
Okay.
So in that diamond, one of those pieces is hypothermia. Okay. We know traumatic hypothermia is different than indwelling hypothermia. Okay. Traumatic hypothermia is a lot lower threshold before you start seeing problems with your patient's clotting factors, with the ability to regulate their lactate and their respiratory rate and their heart rate. You see this one little component start driving a lot of problems that lead to longer admissions and complications. If you can actively do something to help mitigate that, that's a big responsibility and something you should really take into consideration.
Okay. So there's been some talk and some publications regarding CPR and traumatic arrest. And you mentioned it's mentioned in the information that you sent me that among those found not in traumatic cardiac arrest, 96% survived when giving the blood program. With your traumatic arrests, are you administering blood to these folks and providing CPR when you give the blood, or how does that work? Because that's a question I'm sure people are going to ask. Well, if you're not doing CPR, what are you doing for these folks in traumatic cardiac arrest?
So that we treat patients in traumatic cardiac arrest. And the patients that we treat are a special classification of post-traumatic circulatory collapse.
Okay.
I know that sounds a little wonky. Just bear with me.
Sure.
So we do not treat patients in cardiac arrest who are asystolic.
Okay.
If we find you and you're asystolic, our protocol is to pronounce you.
Okay.
So patients under a PEA of 40, okay, we have a skill set that we deliver that's prescribed by our medical director. And if your PEA increases, we will transfuse you and take you to the hospital. If it stays under 40 or degrades to asystole, we pronounce the patient.
Okay.
Greater than 40, okay, there's a lot of literature that says, hey, if they got a PEA over 40, it's probably entry ventricle. Okay, just think about it this way. That ejection fraction, that pump is at 100%. It is trying to squeeze out every little hemoglobin molecule it can. Okay, so those are the patients that we will transfuse, do CPR to, do our skill set, and take to the hospital.
Okay.
Okay. We are working on an ultrasound program Right now, we actually have the devices about looking at ventricles, whether they're full or empty. Okay. So if they're full, it's going to be a different game plan. If they're empty, it's definitely massive transfusion, a unit on the way to the hospital. We can call for a second unit from another supervisor and to make sure we pre-notify the hospital.
Okay.
So there's going to be a lot of advancements that you see coming with this. If any of your listeners went to NAEMSP, there was an exceptional presentation that went on from one of the Delta physicians from Special Ops that talked about the use of ultrasound in traumatic cardiac arrest. You're seeing a lot of places, even I sat earlier on the Eagles podcast with an excellent presentation on ultrasound for another agency in the US who also does blood, and the results that they're seeing by implementing a skill set in a single view. So as this progresses, I think we're going to see a lot of things go and change. And a lot of the hospital-based, what we deemed hospital-based even 5 years ago, is now going to start moving into the pre-hospital arena.
You'd mentioned the ventricles being full versus ventricles being empty. You talked about what happens when the ventricles are empty. What would the course of action be if you do the ultrasound and you find the ventricles are full?
So we're working on that policy right now. It's not something I want to speculate on and then change.
Understood.
So, because I think there's still a lot of research and literature that's coming out, and it really depends on what your endemic population is.
Okay. So we've talked a little bit about some of the hurdles in establishing the program, some of the financial concerns. When you started rolling out or when it started to become a reality for you, talk about some of the training that the paramedics had to go through when you started the blood program.
So we do something a little bit different. We do a full 8 hours of in-person training.
Okay.
On top of 2 pre-course assignments that are graded. We are very lucky that the LifeFlow and the Q&Flow that we use have pre-course assignments that can be completed. So it breaks down the information about the devices, clinical concerns, how to use them, any of the implementation practices, and then there's also an exam afterwards. You have to score an 80, which is great for us. And then you come into our 8-hour session. So the first 4 hours really breaks down a lot of trauma education. We focus on a lot of RDCR, or remote damage control resuscitation techniques, because we have to stop bleeding before we ever put blood in. We talk about a lot of the physiology, and then we get into our policies and procedures surrounding the transfusion event. The last 4 hours are all hands-on. We want you to be in our immersive simulation lab. We want you to be hands-on with the equipment. We want you to walk through a scenario from start to finish for every single patient demographic you can encounter. So we do a pediatric, a geriatric, and then a trauma scenario. We use 2 immersive labs. We also use our immersive ambulances. The clinical reps from the companies play a large role in our training because they are pre-hospital providers, they're flight nurses, they're very well versed in these devices and trauma care.
What are some of the skills outside of the quote unquote normal paramedic skill set that you have to that paramedics train when they're giving blood?
So I don't think anything is outside of the normal skill set. I think it's understanding that rapid hemorrhage control is key. And it's also understanding that jumping on an airway very quickly prior to resuscitation can do a lot of harm to patient outcomes. In trauma care, there's a shift of a mindset, right? And even with some of our very sick medical patients, it's changing that if the person's able to be positioned and support their airway, allow them to do that. So you can put on tourniquets and put on chest seals and do wound packing and stop the hemorrhage, because it doesn't matter what happens to that airway if you don't control a lot of the ancillary or BLS skill level things.
So what are some of the additional equipment as far as the disposable supplies that you need when you're giving blood? Obviously, I would think it would be obvious you can't use standard IV tubing, so there's special blood tubing that you need to use. Is that correct?
So we do. We actually use the LifeFlow device from 410 Medical. So that
Okay.
is actual specialized blood tubing that already has a micron filter in it. And it's actually a designed push-pull device that meets standards to be able to give 10 mLs every single squeeze of the device to deliver warmed or deliver blood into the patient.
Okay.
We use the Q and Flow Light, which is a warmer and will warm blood from 98 to 100 degrees. Does that very rapidly and can do 180 mLs a minute and has a battery life. We have the extended one for either 6 units of blood or 3 liters of fluid.
Okay.
So we know that we can not only give blood in the field, but if the hospital were to have issues with a Belmont or a level 1, or we're walking this patient directly down to the OR, we can continue to transfuse that patient without ever having a break in the warming device.
Okay.
Some of the other things we do is we have a transfusion record that gets filled out. It's a paper form. We use the ISBT stickers on the back of a bag. So if you ever went to a library when you were a kid and they had the ISBN numbers that you could
Mm-hmm.
scan,
Yes.
same kind of concept, except these are just for blood.
Okay.
And those stickers link directly to the patient's chart. That way they know everything about that unit of blood, who it came from, all the transfusion events, and it stays with them. That's actually an FDA regulation.
Okay. Are you using any type of special software in pre-hospital to when you do these scans to link it to your documentation or forwarded that information to the hospital?
So in our charting, we have 2 specific forms that get filled out. First, the transfusion event record gets filled out
Okay.
for the start and end time, what type of consent we obtained. Okay, so was it written, was it verbal, or was it implied? We document what type of blood it was. We document whether it was an IV or an IO, all of those pieces. And as soon as that chart is closed, it automatically gets uploaded into the cloud and attached to the patient record at the hospital.
Okay. Awesome. You mentioned just a couple seconds ago IV versus IO. Do you find a difference in the rate of administration in one route versus the other?
Actually, I can tell you, I just ran the numbers.
Okay.
So for all of our patients, we have done 160, I'll just call it 160 IVs versus 100 IOs. And there is only an 8-second difference in delivery between the two.
Oh, good Lord. That's nice. Very
Yeah,
good.
it's really great news.
Mhm. Now, when the medics are administering the blood, how rapidly are they administering? I think you mentioned a few moments ago something along the lines of 10 mLs. I think I can't remember the time frame, but how quickly are they administering the blood to these patients?
So right now we're looking at an average time of 3 minutes and 44 seconds is our average time for administration. Our median time is 3 minutes.
Okay, and just to refresh people's memories, how much is in a unit of blood?
So in packed red blood cells, it changes the same with platelets or
Okay,
fresh frozen plasma, but in whole blood, it's 500 mLs.
okay, so you're delivering 5 mLs in 3 minutes.
Yep, 500 mLs in 3
Okay,
minutes.
so that's a pretty decent rate of administration.
It is.
As far as how the blood is packaged on the ambulances, do you carry them on the ambulances, or are there special vehicles only that carry the blood and meet the crews at the scene?
So we only carry it on our EMS supervisors. Some
Okay,
people call them duty officers, our EMS
okay,
supervisor vehicles. We have 5 that are throughout the city. And we have them overlapping so we can reach 99.7% of the areas in the city within 10 minutes.
okay,
They are dispatched in all of our critical incidents. So shootings, stabbings, cardiac arrests, motor vehicle accidents with entrapment or injection. So all of the high priority runs in which you would see blood utilized.
okay,
Today, they were dealing, excuse me, with an incident where they were requested to the scene to give blood for a medical patient.
okay.
So we do also have that ability and we track all of that information.
So most people would think, and you mentioned it earlier about medical cases. Most people would think, obviously, if you're carrying blood, you're carrying it for trauma. But you mentioned, like I said, a couple times that you've had to give it in medical cases. Can you talk
Mhm.
to us a little bit about medical situations where you might have a need to give blood? I think GI bleeds are the first thing that come to people's minds, but what are some other possibilities in medical cases that where blood may be required?
Yeah, so that's actually a really good question. We do a lot with vaginal bleeding, either peripartum or postpartum bleeding. We do a lot with ruptured dialysis fistulas or medical devices like a ruptured PICC line, something that was removed or accidentally cut. I know when we talk, especially with people who are in Texas and some other drier areas, they do a lot with nosebleeds
Okay.
and ruptured sinuses. We also have done a couple with ruptured surgical sites.
Okay. So the when on the EMS duty officer or the EMS supervisor vehicles, um, how much blood are they carrying, and are they carrying it in? I would think it'd have to be a specialized temperature controlled cooler. How much space does that take up on those vehicles?
So the good news is it doesn't take up a ton of space.
Outstanding.
We currently, I know, right? Because that's always a concern. How
Hmm.
much do we have to put in there?
Right.
Um, we currently use the Credo cooler with a sensor push, which is an FDA approved device to be able to 24/7 track temperatures. Ours run about every 45 seconds to a minute. We get an update on what that temperature is in that cooler. We're currently carrying one unit. We are hoping to open the discussion, especially now that we have our first year of data, for 2 supervisors to carry 2 units. But we are still working on that one.
Okay.
But we carry 3 separate bags. We carry one for the Q and flow device, one for the Credo cooler itself, and then one for all of our supplies that's sealed. And in total, it's no more than 7 pounds, and you can pick them all up with one of the big Dad Lowe's Home Depot clips. Is the easiest way to
Outstanding.
put it together.
Outstanding. That's a concern that are a concern that a lot of that I've heard from other not necessarily experts, but people is, well, what if I don't get a chance to use the blood? Obviously, with 280 plus administrations in just over a year, that's not a concern. But for those that do have that concern, how would they alleviate that if they feel that they're not going to be able to use their blood in time?
So there are a lot of systems that rotate back
Okay.
to the hospital or to the blood bank.
Okay.
And that's the majority of what you see. Um, and even in larger places like California, they will rotate back. Um, if you are an agency that does not rotate back and you have 1 or 2 units in your system, what you can do is rotate those units to high volume areas. You can track the usage, so that way you're always having whatever that short date unit is, okay, the one that's getting ready to expire, in an area where you know it will get utilized. And that's just a lot of it. It does take time. It takes dedication. It takes somebody paying attention to this on a daily basis to be able to do that.
Okay. Earlier in the discussion, you talked about how you visited the hospitals, talked to
Mhm.
the staff about what you were doing. The first times they started seeing the blood come in, what was the feedback back to the
Mhm.
department on either the patient's outcome or how the paramedics had administered it, or the benefit to those in the emergency department that were receiving the patients who had already gotten the transfusions?
They were excited.
Okay.
And they were excited for a couple of reasons. One of the first ones is the pre-hospital notifications got better. They were stronger. The hospital turnovers got stronger. I can tell you from a personal aspect, if I call in and tell you that I'm giving blood, when I walk into that trauma bay, you could hear a pin drop. They want to hear what I am saying because I have recognized how critical the patient is. And there is excitement still about this. We have patients who are coming in with TRIS scores or survivability scores that are below 50, that are below 30, and we're bringing them in with blood pressures and we're bringing them in, viable to go to surgery, which is something we weren't able to do before.
Can you tell us a little bit about some of the success stories that you've had? Obviously, the numbers that we discussed earlier are impressive enough in itself. But what about the patients that are making it to hospital discharge?
One of the greatest success stories we had is a young patient who sustained multiple GSWs. They were found in traumatic cardiac arrest. They were that true post-circulatory collapse patient.
Hmm.
They were transfused en route to the hospital. When they arrived, they had a pulse. That patient survived not only to rehab, but survived home. And when you look at years of life, the comparative average for a male patient in Washington, D.C., we saved 59 years of life.
Okay.
That's a story that sticks with me. That's a story that is something when you think about it. We transfuse pediatric patients in our program.
Okay.
Okay. And we're at 100% penetrating trauma for them.
Okay.
And to know that if a patient comes in, a pediatric patient with a shock index greater than 1, okay, their risk of morbidity and mortality is 46%. And to know that our numbers for survival for all of those patients, our mortality rate is only 28%. You know you're doing something really, really well.
Right.
You know you're making a difference. You know you're saving years of life. And every time I see one of those patients, I don't want to say I follow them closer, but I do.
Sure.
Because not only is that a vulnerable population, it's someone like, I think those patients will always touch you a little more, but understanding like when you start looking at numbers, the years of life saved when you're changing, you're literally inversing what survival and mortality is huge.
You talked a little bit, obviously you just talked about the patient with multiple GSWs, talked a little bit about bleeding control earlier. Obviously tourniquets are being used, but what other bleeding control methods? Do you have anything out of the ordinary that might be considered out of the ordinary for bleeding control? Or are you just using standard? Are you using any type of clotting agents, combat gauze, anything like that in addition to tourniquets?
So we do. We use combat gauze. We actively wound pack. We
Okay.
do tourniquets. We do pelvic binding. We have a couple of different chest seals that we use. We're looking at some other hemostatic agents as well, especially now that you see plasma products coming on the market. Spray plasma, packing plasma, plasma itself for freeze dried, like all kinds of things are coming out there. And it's starting to look at the research and saying, what can we apply safely for our patients?
Okay. So where do you see your program going in the future? Obviously, you just finished the first year, great success. Talked a little bit about how you're hoping to put a couple extra units on a couple of the supervisor vehicles. Where else would you see your program going, or where else would you like to see the program go?
I think for me, I would like to see, can we expand and build on this? We have a platform for success right now in how we've done training and QA and QI and data collection. And as we move into the ultrasound realm, does that add additional trauma skills, something like finger thoracostomy? We're looking to see, what does Reboa do in the field? Is that better than looking at the AAJSTs, right? Does ultrasound plus an AAJST make more sense, right? Because there is a risk with junctional tourniquets. And it's building on, if we add another skill set, what does that look like? How do we train for that? And in the end, the goal is always, does it save more lives? Does it have the potential to save more lives, especially in our patient population?
So for those that have been listening and have been staggered by the numbers, buoyed by your success, if you will, and have decided that they want to try to follow this path, what are some of the first steps that you recommend for any listeners and agencies that want to start this journey?
Phone a friend.
Okay.
Phone a friend. You have people out there who are willing freely to give their time, and who have worked with other companies to make sure that you can access their time freely. And they can start walking you through the process. I know for me, my first question is, how many patients are you going to give it to? What do your numbers look like?
Okay.
Even if you were to just do a simple query and say, I'm looking for a trauma notification and I'm looking for a blood pressure of less than 90. How many patients did I run in 6 months? How many patients did I run in a year? Or pull your TXA numbers. How many
Hmm.
patients got TXA? You can make it really easy on yourself and start thinking, okay, then what's my average time to a hospital? Do I have time to do this skill?
Yeah.
And in almost every instance, the answer is going to be, yeah, I have the time, and wow, I could really help patients.
Yeah. We had in the area where I work, a couple years ago, we had one of the level 2 trauma centers in our area drop their trauma status. So that put our closest trauma center an additional, depending on where you are in our fire district, an additional 10 to 20 minutes away. So increasing that time to get to a trauma center could have a substantial impact on the patient outcome, and something like this might be beneficial to those patients that really need it, obviously.
And the other thing is, don't get hung up on getting low titer whole blood.
Okay.
Okay. If the blood bank says, hey, we'll give you packed red blood cells, and the trauma surgeons and your medical director are like, yeah, that's cool, take it. If it's
Okay.
plasma, do that. Product, any even component product is better than no product whatsoever. When you look at the research for normal saline, first, it's got a pH of 5.5. Second, when we go back to the old school theory of you give it until they run pink, right? A
Yeah.
lot of us learned that. I've been a
Oh yeah.
paramedic 20 plus years, right?
Me too.
Um, that was what we were doing. We were
Right.
causing cell degradation, right? See glycolax destruction,
Right.
which causes long-term downstream effects, especially if that patient goes to surgery. Don't get hung up on just having whole blood. Is it preferred? Absolutely. But there's a lot of information, especially coming out from people like Dr. Holcomb about plasma and what that can do. So be a little open-minded and
Right.
accepting of what you can get in your region.
I think that's also a hang up that some may have is, well, if I can't get whole blood, what good is anything else going to do? So obviously you've just talked to us about how anything is better than nothing, so to speak.
Yeah.
Switching gears a little bit, and the information on your blood program is outstanding, fantastic, helped me a lot, because if this is a road that we choose to travel, I'm gonna have to go back and listen to this and take more thorough notes on our conversation. But obviously, earlier this year, in your area, there was the tragic midair collision over the Potomac River, involving the Black Hawk helicopter and the commuter jet. Um, we've been trying to schedule this for a couple of months, and we unfortunately had to delay it because you were serving on the incident management team that was helping, that was responding to that incident. For those of us that do work in incident management, and I was deployed to Western North Carolina last year to help with Tropical Storm Helene. Talk to us a little bit about working as part of an incident management team, especially on a situation that received as much media attention as it did and has had as many responding agencies as yours did.
I am very grateful for the support that I had. I'm very grateful. I stepped in, and you can take all the classes and you can do all of the special events type incident management, documentation and all of those things, and you can put together this cute, happy Rolodex of information and all your forms and your sticky notes and your pencils and your pens, and you got your planning P out, and I can tell you it doesn't prepare you for anything.
Okay.
When you are walking into a room for an ongoing incident and you are trying to locate resources and create objectives, and the objectives are ever changing because the incident is ever changing. Working with a team, and having a team that was very, very supportive, was exceptional. I can honestly say I would be very happy if I never had to do another one in my entire career. Um, I can say that will probably never happen working in DC, but I would be very happy to never have to step into that role again. While it was a great learning experience, I think there are still lots of things to unpack from it.
Hmm. Now, your role that you mentioned before we started recording is you were planning section chief.
I was.
So was your team comprised of uh, members from many different disciplines? Were you all from fire and EMS, or who all composed your section, your planning section that worked with you?
So for me, I had people from DC Fire and EMS. I had people from the Coast Guard. I had the Metropolitan Police Department. I had Airport Authority. I had NTSB. There were a lot of people who were there. And there were a lot of people where you had to very quickly develop communication styles. I remember at one point in time, speaking between the FBI and NTSB and Coast Guard, I had a cheat sheet of things that they were telling me because they were just using acronyms, and I would be like, all
Mhm.
right, what does that mean? And I would have to write that down so I didn't have to keep asking them again. Um, so it was good. And there were from the team, there were people who were from different jurisdictions, like the National Capital Region Incident Management Team came in, and they were exceptionally supportive. They helped with documentation and building and charts and maps. And when we were doing briefings, I mean, this was my first time running a true ever-changing planning P, right?
Okay.
And not one of those where you're like, okay, we're 12 hours in the incident. Let's do our incident brief, right?
Mhm.
Let's walk through this. We're still doing the same thing on the 4th of July. It was, okay, what are the new objectives? What are the goals for tomorrow? What are the goals for the next 4 hours? How do we do this? What does our overnight staffing look like? What are your goals for this time period? And comprising that together and then walking through and truly getting verification on every single page of an IAP. This wasn't an IAP where you'd be like, all right, I'm gonna put this down, we're gonna breeze through it and we're good to go, right?
Mhm.
This was, I need your approval on every single page before I move forward.
Mhm.
And one of the things that I noticed is every agency has verbiage pieces that you need to get correct. What might work for the FBI for verbiage doesn't work for the Coast Guard because they mean different things. And how do you put those on the same page?
Mhm. One of the things that I hear when I attend classes, whether it's a specific course or just a general course on incident management or ICS, is interagency rivalries and difficulty with agencies working together. Did you experience any of that in your time managing this incident?
No, I
Okay.
can say with confidence, there was such a mission-driven goal. And there was clear communication and people understood if, let's say, the temperature raised in the room a little bit, people understood why.
Okay.
People were getting tired. We needed to eat. There was a coffee run that needed to be made. Somebody needed to take a break and walk away from a computer screen because this was so heavy. Um, so no, I can say with certainty, and I sit behind me and I know it sounds silly. I have a rack of challenge coins from people.
I can see them.
Um,
Mhm.
like I have a rack of challenge coins. Like my first row is because it was that open line of communication. Like, and you walked into a room where you knew that trust was the most valuable thing at the time. And everyone played to and worked to ensure that that was tight and cohesive.
Mhm. You mentioned a few moments ago, you talked about the IAP and how you needed to get approval on every aspect of the IAP. At the end of the day, and I've heard horror stories regarding the Deepwater Horizon IAP being 800 plus pages. How big was the IAP for your operation?
We were under 30 pages.
Okay, that's outstanding.
I am a clean, concise, put together. If there isn't a form for it, it doesn't live in this document.
Okay.
Now is that different than what we maybe do on other operations? Absolutely. But
Mhm.
this was also knowing and having the understanding that this document is federally reviewed.
Mm-hmm.
This document has to be clean. It has to be cohesive. And whatever that the Joint Command says, that's what we're doing. This is what they're telling me we have to do. This is what we're doing.
Okay.
When you're dealing with five people, and they all get on the same page and they said, all right, this is what you're doing. This is what we expect out of you. Make it happen.
Mm-hmm.
Absolutely. Okay.
So that being said, I would imagine you did not have any trouble getting the information that you needed to compile the IAP for that next operational period.
I'm a very demanding human, sir.
Okay.
Yeah, I have a mom stare, the 1,000-yard mom stare. So we had deadlines when you had to bring me information or bring a team member information, because one of the things I learned was a lot of delegating. And if it wasn't there, you saw the mom stare from across the room.
Okay.
Like you knew you owed me something.
So you had mentioned in our correspondences that you were working out of Reagan, out of the airport. What type of workspace did you have at the airport? Were you in like an office? Were you just in a conference room?
Reagan International Airport was incredibly gracious. They gave us a very large conference space that had the ability to have a divider
Okay.
in the middle, to start separating what was incident command from planning section, from logistics section, things like that. The airport was exceptionally welcoming to all of our team members, no matter where you were from.
Okay. You mentioned some learning experience. What are some of the lessons that you took away that you wouldn't mind sharing for anyone they find themselves working on a big incident with a lot of cooperating agencies?
Listen.
Okay.
And do not listen to respond. One of the biggest things I did is I walked into that room and I listened to what people were saying, and I listened to take notes. And it wasn't until someone was finished with the conversation of what that goal was, what the resources were that they needed, that I responded with, I need you to talk to this person. They can handle this. I need you to do this. And then I need, from my information, you to explain on this part. I worked very, very diligently to not interrupt anyone's train of thought. Right?
Mm-hmm.
To make sure I could get that information, and they were able to give it to me in a way where it never felt broken.
Okay.
So I think that would be my biggest takeaway. And the other thing is, whatever you thought you learned in a tabletop exercise, I know I took a 1-week course and then I took a 2-week course in this. It is nothing compared to the real thing. Nothing prepares you for this.
Yes. Yeah. And I can't imagine what it was like. Like I said, I went to North Carolina after Helene, worked with a lot of different agencies, not as nearly as many cooperating agencies as you had, but I agree with that. It's definitely not like they like in the classroom or at the tabletop. That's for sure. So as we get ready to wrap up, I just want to take time to once again thank you for spending some time with me this afternoon. One question I ask selfishly to help expand my knowledge in reading library is I always ask, what's the last book that you read?
Oh, the last book I read is called Let Them.
Okay.
So this is a leadership book, and it is actually a principle. And it's great, right? Especially when you're dealing with a younger generation, and you're trying to not only coach and build, but allow them the space to fail, but fail upwards.
Mm-hmm.
It really talks a lot about the principles of that. So it's, why would you hinder them? Why would you stop that idea? Why just go let them do this?
Right.
Be supportive if they fail, but also be very supportive of the wins, because maybe they have an idea in a direction you didn't see.
That's something that I've been hearing so much lately is regarding our younger workforce, is it just what you said, let them fail, but fail upwards. So that's outstanding. I appreciate that. Is there any social media you want to leave with us for you to contact you, follow you, anything along those lines? Is there anything on DC Fire on the blood program online that people can look up?
So there is. DC Fire has a whole blood page. You can
Okay.
access it from the main DC Fire and EMS webpage. I also have a LinkedIn page. You can search directly for me. And I post a lot of material, especially journals from Transfusion, or articles from Thor about changing policies and practices and looking at trauma care and blood dynamics. And we also post our newsletters on there about not who we transfuse, but the types of cases we transfuse.
Right. Okay. So DC Fire and EMS, and you have the blood page on DC Fire and EMS.
Mm-hmm.
Okay. And that is fems.dc.gov. Is that correct?
Yes, sir. That's correct.
Standing. So once again, DC Fire and EMS, fems.dc.gov, and then look for their whole blood page or whole blood program page. Well, as we wrap up for us here, we are on social media at not_a_fib_podcast on Instagram. And then you can email us at not.a.fib.podcast@gmail.com. Holly, thank you once again for your time. This has been tremendously beneficial, selfishly for me, because it's given me a lot of ideas if we choose to go down this path. So I appreciate your time.
Thanks, Mark. I really appreciate it. I hope you have a great day.
Thank you very much. And for everyone listening, thank you for joining us, and we'll talk to you again next month.